Good morning, everyone. My name is Jenny Niedenfear. I'm in the Social and Behavioral Sciences concentration, and my capstone is titled A Critical Review and Conceptual Model: The Barriers that Adolescents and Young Adults Face in Seeking Treatment for Endometriosis in the United States. Before I begin, I just wanted to quickly thank my advisor, Dr. Lindsay King, who has been an incredible asset to me during the entirety of this program, especially with our recent publication on vulvodynia, her guidance on my capstone, and also her help in getting me accepted into the PhD program in Texas. I really could not have done all of this in the last year without her, so thank you, Dr. King. I'm going to begin by providing a quick overview of what endometriosis is, give definitions on what a critical review and conceptual model are, describe the methods on what I did to conduct this capstone, and then I'll dive into the results, implications, and provide guidance for future interventions. So what is endometriosis? It is a chronic inflammatory condition where endometrial-like tissues, lesions, and adhesions grow outside the uterus. It is believed that 1 in 10 people with the uterus have endometriosis, but this number is actually believed to be substantially underdiagnosed due to delay in diagnoses that can occur on an average up to 4.4 years, sometimes even up to 15 to 20. People may have debilitating symptoms such as dysmenorrhea, bloating, gastrointestinal issues, and dyspareunia. There really is no unified theory to why it exists, and scientists and researchers are still continually puzzled by this disease. Endometriosis is characterized by stages, stage 1 being characterized as minimal lesions and implants, stage 4 as widespread, consisting of deep infiltrating lesions, adhesions, and cysts. Stages do not correlate with pain. While people may respond to pain differently, you can have stage 1 and actually have severe pain, and stage 4 and even have minimal pain. So there are minimal methods of diagnosing endometriosis. The gold standard is laparoscopy, which is a minimally invasive surgery with a scope that's inserted into the abdomen. Imaging techniques are just not reliable enough. You can have stage 4 endometriosis and still have negative imaging. The methods of treatments are also pretty limited. They can manage the disease, but they're not effective enough as there actually is no cure for endometriosis. The formal paper that I've written for my capstone is known as a critical review. According to Grant and Booth in 2009, this type of review demonstrates that the writer has evaluated the literature and critically assessed its quality. So it's going beyond just description and results in a hypothesis or even a model. With this type of review, there's no formal assessment, no formal search terms, no operationalization of the constructs, or even quality assessment. I found this most fitting for my subject topic as there is minimal literature on endometriosis, especially in the connection of it to public health theories and models. I have chosen to utilize a conceptual model for my critical review. As defined by Earp et al. In 1991, a conceptual model is represented as a framework that ties constructs together. They draw on theories to represent and understand a health-related problem. And these models are often seen as a launch pad for future research and concept development. The main aim of this model review is to educate providers on the barriers that patients face in seeking treatments, provide insight on how to reduce these issues, and identify ways researchers can work to create new interventions. My target population are young adults and adolescents ages 10 to 25 years. So the onset of menstruation begins at ages 10 to 13 years of age. Some patients actually experience painful symptoms immediately that are consistent with endometriosis, and this aspect is often overlooked by providers. The earlier that young adults and adolescents can identify the causes of their pain and receive treatments, the more likely they are to benefit from early prevention strategies and prevent long-term damage to their internal organs. For my methods, I conducted an initial systematic search. As critical reviews do not really involve a rigorous systematic search, I chose to include 29 papers up front. The papers that were excluded did not fit the research question. They were not focused in the United States. They had no relevance to adolescents. The articles were focused on various treatments, and they were not associated with help-seeking behaviors or barriers. I found an additional 45 papers that were deemed as relevant to my research topic. I ended up with a total of 74 papers in my review, and these were classified into specific patient barriers after critically analyzing the text. And my research question is, what barriers exist for adolescents and young adults ages 10 to 25 seeking treatment for endometriosis in the United States? So for my conceptual model, I used 5 key theories and models to answer my research question, which I'm going to present one by one. I'm going to start with the CDC's social ecological model, as I used it for the backbone of this paper. This model inserts individuals in intertwined levels that interact with each other. I'm going to elaborate on the individual, the relationship, the organizational, and policy levels, and how barriers can occur for patients at each level as they pursue treatment for their pelvic pain. This is my conceptual model that reads from left to right. This is one of the first public health models that links constructs in relation to endometriosis, and I do plan to submit this for publication after I complete this class. The constructs from the literature have a strong justification to be paired together with each theory and model. Each construct is representative of where patients encounter barriers at each level of the SEM. Starting with the first part of the model, I'm using three constructs from the health belief model. This model posits that people are likely to engage in a health behavior if they believe that they are susceptible, at risk, have serious consequences, and that there are benefits to taking action and seeking help for endometriosis. The perceived benefits would be believed about the positive aspects of adopting a behavior, which would include that treatments could possibly provide some relief, treatments could remove the disease, and that one could have more energy to go to work and engage in activities. On the other hand, perceived barriers are represented as not being able to keep with work or school due to the time spent seeking help, having little motivation or energy to seek help as well. For this construct, endometriosis is perceived as low priority. The barriers simply outweigh the risks. Self-efficacy, which is a key construct in the HBM, is characterized as the ability to seek help, cope with the pain, advocate for oneself, and understand endometriosis treatments. This is the construct that cues individuals to action, but if an individual has a lack of self-efficacy, that can actually serve as a barrier. Next is the interpersonal level of the social ecological model, where I'm using constructs from Bandera's social cognitive theory, observational learning, and outcome expectations, and I'm also using the idea of social support. Social cognitive theory is used to show that there is a reciprocal determinism between cognitive factors, behavioral factors, and the environment. So for observational learning, which I'm using, individuals are represented to learn behaviors through observations or through the social support that they receive. Individuals may make judgments about the likelihood of the consequences of performing an action. Those who observe that they can receive an endometriosis diagnosis, receive pain relief, or even get treatments faster by seeking help may be more likely to seek the proper help that they actually need. For outcome expectations, Gupta et al. In 2018 has suggested that workplaces and schools can either promote or not promote health-seeking behaviors within specific environments and conditions. Individuals may actually have certain expectations to what seeking treatment could entail, which actually could serve as a barrier if the expectations are negative. Next, I'm focusing on emotional support, which is characterized by expressions of comfort in caring. Individuals may receive or not receive emotional support from family members, colleagues, significant others, and social media platforms. In a study by Sims et al. In 2021, participants reported that their family members did not support them and dismissed their menstrual pain altogether. This lack of emotional support resulted in less health-seeking behaviors as their family members deemed these menstrual pains normal for people to endure. Next are the environmental and structural determinants. The aim for this part of the model is to enhance understanding of the environmental forces that act on individuals and may contribute to barriers such as health disparities, stigma, and racism. Social factors are represented as fundamental causes of disease as they prohibit access to important resources and affect disease outcomes. Stigma is defined as a force between diagnostic delay and even contributes to a decrease in psychological well-being. Menstrual cycle stigma is very prevalent in our society even today as of 2023. Painful cramps and heavy bleeding are still normalized as just representing a bad period. Harmful euphemisms may also prevent people from discussing menstrual pain openly. The built environment can prevent people from accessing healthcare services. Many patients may experience huge barriers in just having unreliable transportation, even just to get menstrual products or seek out doctors who specialize in minimally invasive surgery. The top quality endometriosis surgeons who specialize in this area are often not in network for some patients and often require patients to travel out of state. Cost is also a huge issue. Several studies have been done to show that patients have a high amount of emergency room utilization. In a 2021 study, the average cost for endometriosis treatment per year was $13,133 in the United States, while another review found the cost to be ranging from $1,450 to $20,239. This variation is due to out-of-network services and treatments and variations in severity of symptoms. Another main issue is lack of health literacy. At least 80 million adults are reported to have low health literacy. Patients who don't understand the doctor or why they're being asked to do things can contribute to delays in diagnoses and improper treatment. In a study by Dahl et al. In 2020, participants were reported to not recognize or understand unusual menstrual bleeding and menopausal symptoms. These authors suggested that this inability to recognize these symptoms were due to having a low lack of health literacy, and this could actually lead to a delayed diagnosis of other similar reproductive issues, not just endometriosis. Major barrier I want to touch on is racism and discrimination with regards to patients, as these are negatively associated with health behaviors and the inability to access healthcare and treatments. And this topic really needs a whole presentation on it. Recent studies have suggested there to be a major existing disparity in white medical staff over treating other white patients for pain, while Black patients are reportedly undertreated. Solomon et al. In 2019 showed that the majority of patients in these studies are white. As with other indications, previous historical events have contributed to the lack of Black participants in research studies, so the current existing literature is just beginning to touch on racism and bias more in gynecological settings, so we should see more efforts to include other races in the future. Now we've come to the last part of the model where I will be discussing experiences and outcomes. As a result of the barriers mentioned, we are now at the experiences column. Several studies suggested that individuals may lose out on quality of life, sleep, social experiences, and the ability to participate in activities. People can also miss out on educational and career opportunities. Chronic pain and progressive symptoms can result in the loss of interpersonal relationships as well, and discrimination and racism should be included at this level. Outcomes are characterized by the individual either accessing or not accessing treatments. The individual may experience pain relief or no pain relief at all. The variety of treatments are listed in the model, such as surgery, multimodal imaging, birth control, and pelvic floor physical therapy. Based on my findings, people that were reportedly more economically stable are able to advocate for themselves and are heard, listened to, and supported by their doctors, actually receive the best outcomes and are able to access treatment. Now that I've fully explained the model, I'm going to move on to limitations and then close with interventions to overcome these barriers. There are several limitations worth mentioning that are multifaceted for this review. A critical review serves as a strong format for this research aim, but given that this review is non-systematic, it's actually very difficult to replicate this search strategy. Selection bias could have occurred as most of the studies only include white patients, so there's clearly an overrepresentation of the white population in these studies. The majority of the studies are cross-sectional, which makes it difficult to generalize to the rest of the population. Most of the studies only focus on one or two aspects of endometriosis. Patients are generally not followed over time, so you do not see the long-term outcome of their care. Construct underrepresentation or potential misspecification can occur. Other alternative models may actually exist that could better represent this issue. And finally, given that a large stigma exists surrounding menstrual cycles and pain, this critical review is in no means inclusive of the issues that exist due to dearth of publications, and many of the reviews have self-reported patient responses. I have provided some multidisciplinary approaches to reduce patient barriers and improve patient health outcomes. We really need to approach this from all levels of the SCM. We need more awareness of the disease. We need more media campaigns, more educational programs at the provider level with revisions of medical textbooks and licensing. We also need more trauma-informed training for providers. At the policy level, more research and advocacy efforts could be geared towards discovering the factors that promote equalities and inequalities in our healthcare system in order to reduce societal barriers. Treatments are just too out of reach, unaffordable, and too little is known about the disease itself. I'm going to close with the idea that more research is needed for providers and public health professionals to help endometriosis patients get better care and treatment options. There are just too many barriers for patients at every level of the SCM. I believe this model can be used to guide behavioral research, public health interventions, and program development. With more interventions and collaboration among providers with public health specialists, we could drastically improve the lives of people with a uterus and work towards creating a better future for patients. Thank you, and now I'm ready to take questions.